Hi everyone, thanks for joining this Becoming a Doctor session again. So this will be just a general haematology overview aimed at clinical year students and will be delivered by Genevieve Hirsz. So just a few ground rules to explain how it works. The chat feature, any questions you have about what's currently happening on the tutorial, put it in there. If you have any questions that can wait till the end, put it in the Q&A area. And regarding to the polling and the questions, if you are watching it on the Zoom, they will pop up on your screen. If you're watching it on the Facebook, you will not be able to interact with the poll, but still answer the question for your own learning. But otherwise, that is all from me. Dr. Hirsz, if you want to take it away.
Okay, hello, can everyone hear me? I'm hoping that's okay. So my name's Jen. I'm working as an F1 in Adam Brooks Hospital. So my background is that I've done 4 months of haematology. So haematology is a very post-grad subject. So bear that in mind. I'm not a consultant. I'm an F1 who's done 4 months of it. I also did, when I was doing the pathology exam in my 5th year, I thought that haematology was the lesser of all the evils of pathology. So that's why I actually did very detailed haematology pathology notes. But I know this is supposed to be aimed for clinical years, so I'm only going to be going to pathology if I think it helps it clinically. I prefer things clinically anyway than pathology-wise. So if we start, let me show this from the beginning. So little disclaimer explaining all that I've just mentioned as well. And then the learning objectives. So I know that I've kept this very broad. Haematology is also a very broad subject. You can go into the red blood cell areas, you can go white cell platelets. So I wanted to go through things briefly because I think generally, especially because haematology is very postgrad, it's easy to get bogged down in the details of one particular area and not really get a good overview of haematology. So that's why I wanted to try to cover lots of things very briefly, so that even if I don't cover something in as much detail as you might want, you know that you can go into that area in a bit more detail and then go through, see what I haven't gone through in as much detail and, fill in the gaps yourself. But at least you know where the gaps are because I've done a brief overview. So I want to go, particularly, I have looked through some past paper questions. So I've tried to do this based on what questions I've seen come up. There are definitely questions on blood transfusions. This is also important for you. You will be asked all the time as an F1, whatever specialty you're on, to see patients who are having some sort of blood transfusion reaction. Anticoagulation, again, you're going to be asked about this all the time as an F1, but this also comes up in exams. You will have, so I did surgery as my first 4-month placement, HPV surgery, and yeah, blood transfusions, anticoagulation, that's actually, I saw more of that on surgery than on haematology. Then a quick overview of prothrombotic sort of bleeding states and conditions, because that comes up in the exams, and what you need to know clinically as well as an F1. Cancers, this is where I was working as an F1. I was working on the transplant wards. I was working with patients with leukemias, lymphomas, myelomas. What I'm going to be doing is that for the actual exams, cancers is a very buzzwordy topic. My advice would be to just do questions on them. You'll pick up the buzzwords. I've got a slide. I've left some of my own notes at the end that I don't think I'm going to have time to go through, and you can just take them, read through them in your own time, add to those notes as well. So I've started making a sort of buzzwordy list for some of the leukemias, and you can just add on buzzwords as you're going through questions. So I'll briefly go through the clinical presentations. I know that it's going to be all the clinical years. So I'm not sure how much you younger clinical years how confident you are with your cancers. So I'll briefly go through the presentation and then the investigations, because that goes into a lot of detail for the haematologists, and then go through complications because that's what I was dealing with on the wards. And then a little bit on hemolysis. This is again quite a sort of, like I'm taking this from my path notes and kind of explaining a brief overview for how you can look into hemolysis. It does come up clinically though, it is, you will come across it as an F1 as well. So that's why I've picked all these topics essentially. But things like anemias, I'm not, apart from the hemolytic anemias, I'm not really going to be going into iron deficiency and, megaloblastic and all those sorts of things, because I think that's covered quite well. And I think you can also read through that in your own time. So first of all, we'll start off with the blood transfusions. Why, how, what type, what are the complications? So what you'll be doing as an F1, just very briefly, is that you're going to be you need to take 2 group and screen or group and save bottles. If the patient's already had one on a previous admission, then you only need to take 1 extra, which they're only valid for about 3 days when you're going to give the blood transfusion. these are supposed to be given, they're supposed to be taken at least 15 minutes apart, preferably by different users taking the blood. You have to handwrite on the bottle and you have to fill out a form for each, but you have to give the indication for why you want this blood transfusion. You'll have this in your induction as well as an F1 of like, how do you, consent people for blood transfusion, things like that. I won't go into too much detail because that's more like an induction topic when you're actually in F1 rather than exam questioning, which is what I'm going to focus on. So generally what you want to do is you want to aim for a hemoglobin of above 70 for most patients. It's above 80 for certain patients like hematology patients and some with like severe cardiac conditions, ischemic heart disease type things, where you want to keep the hemoglobin level a little bit higher. And then it tends to be very roughly, when you're on surgery, you're going to probably be giving it because of an acute bleed. When you're on the medical side, it's probably going to be due to a chronic anemia. For platelets, the lower level of normal is 150, but you don't actually need to give someone a platelet transfusion unless they are in the single digits. So you want to keep it above 10, above 20 if they're having fevers, because they go through their platelets more quickly. And then for different procedures, you have to have them at different levels. Above 30 for a Hickman line, you don't need to for a PICC line. Or that's, according to our vascular surgery department anyway. Above 50 in general for surgery, above 100 for your platelet level for neuro-opthal procedures, lumbar punctures, that sort of thing. Then you have these weird, when you're doing your group and screen form, I don't think I've seen any questions on this, but when you're doing your group and screen form, these are the sorts of things that come up. I asked before I gave this presentation, I asked some of the hematology registrars, like, what do you want, like medical students and F1s to know? And they said, this is the type of thing that people get wrong all the time, because they panic and they select these options when you don't need them. And then actually they often need to be approved by hematology registrar. So it just delays you getting the blood transfusion to your patients. So only use them if you need to. Usually, I don't know how it is in other hospitals, but at least in Addenbrooke's, when we have to, when we pick one of these options, when we have Epic, the computer system for ordering these blood transfusions, and it'll come up as well with conditions for when you want to use these, but it's not obvious. I think most people who even use the system at Addenbrooke's aren't aware of that. Essentially for CMV, you're only giving it to neonates and pregnant women. I've never had to give CMV negative blood to anyone so far, despite doing 4 months of hematology. What I usually have to do, and this is only for auto and allo stem cell transplants, is that you need to give them irradiated blood. It comes up as a flag on the system, but and I think there might be some other things, but that's the main reason why you might be giving irradiated blood. What they do when they irradiate the red blood cells is that they are killing the donor lymphocytes. You have a very small amount of donor lymphocytes and red blood cells, but that's what they're doing with the irradiation. And this is important for one of the blood transfusion complications. So I'll go through that in a moment on the next slide. And then the other thing is you might give washed or HLA matched, and it tends to be if people have had an allergic reaction to platelets or red blood cells before. Generally, what happens when you're giving someone blood transfusions, if you're giving red blood cells, then if they're not, I say roughly, other people might have other numbers, but I say generally, if you're giving red blood cells or platelets, the person should be increasing by about 10 per unit. For hemoglobin, if it's not increasing, if it's increasing less than you're expecting, then it's probably because they still have a bleed somewhere that you still need to manage properly. If for platelets, if they're not increasing as much as you're hoping, if they're not incrementing well, then you can send off for HLA bodies. Generally for red blood cells, people have when you get a bag of red blood cells, they tend to be from one person. But when you have a bag of platelets, of FFP and all those sorts of things, it tends to be pooled from multiple people. So because you're exposed to a lot more antigens, people are more likely to have an allergic reaction. And so then they start getting HLA antibodies to platelets. So you want to give them HLA matched platelets. But if you think people aren't responding to platelets well, you basically just contact a hematology reg and they'll do HLA typing on the patient. So these are the different complications. This flow chart I've got on the side, I have, so I've taken this from a big diagram. I've copied and pasted that massive diagram and I put it on the slides at the end. I don't think you could read it very well. So I've just got a smaller part for looking really at the diagnosis of the different complications. So this is something that you'll be commonly asked to sort out as an F1, and this is something that I've seen come up in exams as well. Essentially, I think people like to go through it by conditions, but I think it's a lot easier to just go by the symptom you'll be asked about. So generally what happens is that you'll be asked to, you might be asked because the patient's got a rash while they're having like a platelet transfusion. If it is just a rash, so you should go and review the patient, you know, check their the label on the blood bag compared to the patient's wristband and confirm it with the patient as well, ideally, all these sorts of things, check that they're well, check their OBS. But if they are literally just having rash, otherwise they're completely fine, you can continue the blood transfusion at a slower rate and just give them an antihistamine, give them chlorphenamine or something. And this is what you'll be more commonly asked to see, is you'll be told by the nurse that the patient is having a, sorry, just checking the chat as well. So what will happen is that if you'll be asked by the nurse that to come see this patient because the patient has just had a bit of a fever. Most of the time, you just have to check, does the patient look well? If a patient is having a severe transfusion reaction, they tend to be having, they look unwell. They're sort of shaking, they're rigoring, they might be having chest pain, dark urine, and other sort of symptoms and signs of hemolysis reaction. But one thing generally you should be able to do as an F1 is just look at a patient at the end of the bed, and before even doing anything, just say, does that patient look well or does that patient look unwell? If that patient looks unwell, it's a severe transfusion reaction. If they look well and all their OBS are fine, all they've had is just a bit of a temperature rise, then they've probably had a febrile non-hemolytic transfusion reaction, which is way too many words to say that they're literally just having a fever. There's nothing else that you need to do as long as they're completely well. And in that case, all you do is you give them paracetamol to bring that fever down, and you slow the rate of the transfusion again, but you can continue it. The other things that you might be, these are the other things that are in the severe transfusion reactions. So if you have someone who's had a fever, then they might have ABO incompatibility. They might be having a hemolytic transfusion reaction. So all those sort of symptoms I was saying of them having hemolysis, that is, they're going to look unwell. The other thing is, when you're checking the patient's, when you're checking the blood bag and you're checking it against the patient's label, have a look at the bag itself, have a look to see if there's any obvious contamination in the bag. They might be having a bacterial contamination of the bag. In that case, you're kind of continuing with sepsis 6 and contacting your seniors. For these severe transfusion reactions, there's a general protocol that you're going to be following. This flowchart does have, in that big one that I've got in one of my slides later on, it does say exactly what you need to do for the management. But generally what you want to do is you want to stop the transfusion. To be honest, you've probably asked the nurse to stop the transfusion before you come and review the patient anyway, but you're not going to continue it at a slower rate, you're just stopping it completely. And then you're basically going to be going through A to E for the patient. And make sure that the blood bag and the giving set is returned back to the lab because they want to be doing testing on it. For example, there was an ABO incompatibility, that's like a never event, so why has that happened? The other reason why you might be asked to see a patient, you know, when the nurse calls you on the phone, this patient who's having a blood transfusion, is that they're now feeling a little bit short of breath or their O2 sats are a bit low. In that case, you're really worried about anaphylaxis. And then in that case, you're going to be following after you've done your A to E assessment, you're going to be following the anaphylactic guidelines, you know, giving your adrenaline, giving your hydrocortisone, giving your antihistamines again. And again, as I said, stop the blood transfusion, take the bag and give it back to the lab. Then you've got your Trali and your TACO. If they're not having anaphylaxis, but they're a bit short of breath, TACO is transfusion-associated circulatory overload. And that is essentially, red blood cells are a very potent fluid. So in TACO, it is that you've just overloaded the patient with fluids. It tends to be a patient who's already got a history of heart failure or something. They might mention that in an exam question. You want to do a chest X-ray. On a chest X-ray, it's going to show they've got pulmonary edema. Assess their fluid status. They might look a bit overloaded. Their JVP will be raised. And this will be happening often while they're having the transfusion. It's often in cases as well where you might have a patient who has, you'll get patients who have chronic anemias, and you'll get patients who come through the door with a hemoglobin of like 40, and you're like, oh my God, okay, they're 40. I need to get them to above 70. So I need to give them at least 3 units at once. But you should not be doing that, because that's how you fluid overload patients. What you should be doing is you should be doing, because these are chronic anemias, these are patients who have kind of got used to having quite a low hemoglobin. So if you give them too much too quickly, they just get overloaded. So you want to give them 2 units, and you'll check their hemoglobin afterwards to check that they're responding appropriately, or have they got some sort of bleed that you haven't picked up. The other possibility is Charlie. So again, you're doing a chest X-ray, but and the patient will again have a sort of fluid overloady looking like picture, as then they have like a pulmonary edema. But the way that a Charlie works, which is lung injury, is that it can happen up to 6 hours after transfusion, and it's when I don't think they're fully sure what the pathology is, but it tends to be that the neutrophils are activated around sort of the capillaries and the alveoli interface, and it's actually caused injury to the lung. And so what happens is that they can get a sort of ARDS type picture, and they just need support. So they might actually need to go to ITU for ventilation. So whether it's a TACO or a Trally, make sure you've got a chest X-ray, making sure, generally because they're overloaded, there's too much fluid in their lungs. You want to be giving them oxygen, and you want to be giving them diuretics, and following the rest of the transfusion protocol with giving the blood bags and everything away to the lab. Other complications. Ooh, perfect. Yeah, so these are things in my notes. These aren't really things I think you'd be coming across as an F1. I haven't seen them much in the exam world, apart from the more obvious ones. Obviously, you get your iron overload patients who've had thalassemias and need regular blood transfusions. They get a lot of iron, and it affects their liver, and so you need to just give them iron chelation to treat it. You get your transfusion-transmitted infections like hepatitis C. You'll learn in your induction and things of how to consent patients for it, but they've now changed how they give blood transfusions to people, like how they process the blood. So the risk is actually very low now. Then you get your weird things like the delayed hemolytic transfusion reaction. So they're still presenting with hemolysis type symptoms of anemia, chest pain, shortness of breath, might have sort of dark urine, the bloods, which I'll go through in more detail later. And they also get some renal failure, but I haven't actually come across this that much. Then you've got your post-transfusion purpura rash, which can be sort of 7 days later. It's again sort of another immune response, so you want to give them IVIG to treat it as an IV immunoglobulins. The other one is TA-GVHD, is transfusion-associated GVHD, and this is the reason why you give irradiated blood products to allo or auto stem cell patients. What happens is that, so with graft versus host disease, it is the graft, what you've transfused into the patient is attacking the host. Does that immune system is attacking the host because the host is so immunocompromised because you've given them chemo and radiotherapy and things to immunosuppress them. And also they've got a cancer anyway, which has wiped out their immune system. So as I said, in red blood cells, there are sometimes some lymphocytes still there. And so in a transfusion-associated GVHD, it is those donor lymphocytes are attacking the host. This has a really high mortality. So my understanding of this is that you will not definitely be giving a patient, if you accidentally did not give them irradiated blood, you wouldn't definitely be giving them this. But because the mortality is so high, like it's above 90, I'm pretty sure I've been told it's sort of 98% or so. It's just not worth it. And so they just give irradiated to everyone who is a stem cell patient. So that's what we do. Those are the guidelines. So we'll start with the first SBA. We'll see if this works. So SBA 1, we're going to, right, I've opened the poll. Let me get the question up and the options. So this was a question that I have, this was a past paper question that I've borrowed. That's good. If I give you guys about a minute, does that seem fair? I mean, about 75% of you voted already, so that's very good. Okay, so I'm going to stop that there. Good, and show the results. Okay, so the reason why you want to check the blood transfusion bag, and I had to, so bear in mind that I've borrowed these from people who have remembered past paper questions, so it's not worded perfectly. I've specifically tried to word it so that it's the next most appropriate step. What you want to do when you're reviewing a patient is you want to check the blood transfusion bag against the patient's details, even if the patient looks well. And so like on my system, I can check their obs before I even go see them. You should always be checking the blood transfusion bag against the patient's details, because that is a never event to give the wrong bag to the patient. You want to do that before you're restarting the transfusion rate or anything else. Like that's just part of your assessment before you do any of this. So these other ones I'd say are kind of your treatment options, whereas the checking the blood transfusion bag is sort of part of your assessment. Stop the transfusion, return the bag, and giving set to the lab. I mean, you will probably have stopped the transfusion before you came to review the patient, but that is not part of your final management. You can restart this because the patient's well. So that's fine. Does that all make sense? I hope so. Okay, so now I'm going to go through anticoagulation. This is quite a guideline-y area. So I'd say check the guidelines yourself and make sure that you're using the most up-to-date ones anyway. And it's literally just learning the guidelines. It's not a particularly exciting topic. Oh, we're going to start with another question. Okay, so I'm launching the poll now. Obviously, this is a bit more unfair because I haven't actually gone through the topic yet, but okay, it looks like it's maybe the last few voters. Right, I'm going to stop it now. We'll have a look through the results. So most of you have been right, which is good. Shows that you've probably already done a little bit of this already. So the reason why I put this question is, again, it's one that's from a past paper, but it's, I think, quite a good way of kind of going through what all these different things are. I don't know if you're all aware of exactly what prothrombin complex is, or if it's something that you just heard it enough times that you just remember it when you actually saw the question. But so prothrombin complex is rich in clotting factors 2, 9, and 10, and sometimes 7. So that is why for a patient with warfarin, because warfarin works, you know, on those clotting factors 2, 7, 9, and 10, the buses that go between Kensington and Hammersmith, or it used to. I don't think it does anymore, so sorry guys. But it's rich on those factors, which is what warfarin affects, and so that's why you want to be giving prothrombin complex. What you can do is you can give FFP, because FFP is rich in all clotting factors, because it's plasma, fresh frozen plasma. So you can give it, but it's not as good as prothrombin complex, just I think because of sort of supply and demand type thing as well, that you want to be just giving the most. There's generally quite a low supply of all these products, so you just want to be giving the prothrombin complex and not wasting FFP if you've got all these other clotting factors that you're giving that you don't need to give. Cryoprecipitate is rich in fibrinogen. Generally, I'd say you're not going to have to be dealing with fibrinogen. The only time I've really come across it while on my heme rotation was that in trauma, you get weird coagulopathies. And so they're measuring you know, PT, APTT, fibrinogen, and then replacing it. So if the fibrinogen's low, they're giving cryoprecipitate. But otherwise, the average person, they're not really going to be low for fibrinogen for a certain reason. So you don't really need to be replacing it for all these conditions that I'll be covering today anyway. Mannitol, osmotic diuretic. Like I'm guessing it's there because it's a hematoma. There might be a bit of raised intracranial pressure, but not necessarily. There's nothing in the question to indicate that, like papilledema or anything. Protamine sulfate is particularly for heparin. It reverses heparin, which is not being mentioned in this question. That is fine. So I'll go to this. Yeah, so generally what happens is that when someone's had a bleed, you're going to be, it doesn't matter if they've had a big bleed or a little bleed, you're going to be stopping their warfarin, and you're going to be giving them 10 milligrams of vitamin K IV. Oh, sorry, I'm just checking the questions in the Q&A. I think I've answered your questions in that when I was going through the answers for that. So generally, if you've got a bleed, any type of bleed, you're going to be stopping their warfarin and you're giving them 10 milligrams of vitamin K IV. If it's a major bleed, you're also giving them prothrombin complex because it's got the 2, 9, 10 plus or minus 7, or FFP if it's unavailable. And you can eventually, I mean, to be honest, if this is happening, you're definitely getting your seniors involved, you're getting hematology involved properly to decide when to restart warfarin, especially if someone's had like an intracranial hemorrhage, which would count as a major bleed. If they come in and you test their warfarin and they're not bleeding, but it's above 8, you stop their warfarin and give vitamin K anyway. Probably give it orally, to be honest, if they're not bleeding. And then if they've got a high INR, but it's less than 8 and they're not bleeding, then you can restart. Then you just hold the warfarin and restart when their INR is less than 5. And then you probably want to reduce the dose because they're probably on a dose that's a bit too high. Or check, warfarin interacts with so many other things. Just check check if they've started any other new medications. Check if they've drastically changed their diet and they started eating loads of grapefruit or something. That's fine. Right, okay. Sorry, I'm being a bit old-persony with using Zoom and PowerPoint, so apologies for that. So for venous thromboembolism events, what you want to do generally is going to be that if you've got a DVT, PE, the other thing that I've seen it for has been like a portal, a venous sinus thrombosis. That's fine. Sorry, checking questions at the same time. Then you're generally giving a DOAC or warfarin. Well, you're going to be considering starting them later on that, but you want to be giving them treatment dose, low molecular weight heparin for 3 months. If it's an unknown cause for their PE or DVT, then you want to be giving it for 3 to 6 months, usually 6 months, but again, you could check with the hematology reg. If it's cancer, you want to be continuing their low molecular weight heparin for a longer time. I say contact the hematology reg to find out exactly how long, or you might not even have to contact the reg, you might just refer them to anticoagulation clinic to decide on their long-term management. If they had a DVT or a PE and then they've had their 6 months of it and then 2 years later they've had another one, then they're having recurrent events, so then you want to just keep them on lifelong. You usually change them from low molecular weight heparin to either warfarin or DOAC. If you're moving them onto warfarin, to be honest, more and more people are being moved onto DOACs because it's just easier, but if you are starting them on warfarin for some reason, then you want to make sure you bridge with the treatment dose low molecular weight heparin, because warfarin is pro-thrombotic for the first few days when you start. So you want to be measuring the INR, making sure it's above 2 for 2 days to show that the warfarin is now having an anticoagulating effect rather than a pro-thrombotic effect. This is what you'll be doing as a surgical F1, that you're going to be asked, or what will happen as an F1 on surgery is that often when a patient is coming in for surgery the next day, you're the doctor who's clerking them in the night before, and you just essentially, they should already have a list of all the medications from a previous clinic with a consultant where they say which drugs they're supposed to stop when, but this is, and you just need to check that they've been doing what the letter said. But this, if you want to know as well, DOACs 1 to 4 days before their surgery, warfarin 4 to 5 days before the surgery. Antiplatelets, aspirin, clopidogrel need to be stopped 1 week prior to surgery, maybe more. This is why they'll have a clinic appointment with their consultant to decide this. You can give someone prophylactic low molecular weight heparin up to 12 hours before their surgery. So usually you can actually give it to them the night before, because no one's having surgery before 6 a.m. really. But if you're not sure, just confirm with your senior. If they've got like bad chronic kidney disease, I haven't seen many people who have had bad chronic kidney disease requiring surgery, like an elective surgery. But if they are, and you can't give them low molecular weight heparin, you can give unfractionated heparin instead. It's a lot more intense, especially if you use an F1, because you have to be monitoring it and adjusting it. So you monitor their APTT, and you're adjusting the dose of the unfractionated heparin based on that result. There should be local guidelines telling you what dose to give them based on the blood result that they've had. It's a bit of a pain. And when do you start the low molecular weight heparin afterwards? Usually in the operation notes, they will say, you know, operation went fine, no bleeding risk, you can start them on the molecular weight heparin that evening. And if it is a major surgery or for surgery for cancer, so on HPV surgery, we had a lot of patients who had like Whipple's procedures and things like that. That's a major surgery. So if they went home in under 28 days, which most of them did, then you made sure that you sent them home with low molecular weight heparin for them to take. So they were taking it for 28 days post-surgery. But again, you can generally confirm with seniors for all these things, but these are sort of the guidelines that I found. All of these guidelines are based on NICE guidelines, by the way, so you should be able to find it relatively easily. So this is a thing that I think was, if I go through quick prothrombotic bleeding states, it comes up quite a lot in exams. I feel like hematologists like to talk about the cancers, or they like to talk about the anemias and the anticoagulation. I think they teach it somewhat, but I just think it's a topic that's not as well taught as some of the other hematology topics. So if we start with another question. Launching the poll now. Just answering some of the questions. When would you use FFP? I'm going to go through that. If you could remind me at the end if I haven't answered that through my later questions. DOACs are not prothrombotic when you first use them, so you don't need to use, you don't need to bridge with low molecular weight heparin. Usually you can just switch them straight away. If renal failure patients are given anticoagulation post-discharge, to be honest, if I had a patient who had such bad renal failure that they needed to be switched onto like a really bad renal failure with AF, I'd definitely be talking. I haven't found anything in the guidelines, obviously, for that. I'd be talking to my seniors. I'd be referring them to anticoagulation clinic. I'd be tempted to give them a DOAC, I think. Oh, actually, I'm really not sure, because usually a lot of the renal failure patients are going to be on dialysis, so I'm not sure how the drugs interact with the dialysis. So not sure about that question, sorry. How are you getting with this question? Stop that now. Nice. So I don't know how this is done. So the answer is lupus anticoagulant. So exactly did type that. So I'll explain that in more detail when I go through these different. Okay, just as a brief reminder, so you've got Virchow's triad on the right. I've generally found it useful to refer back to this whenever you're looking at anticoagulation or prothrombotic states and things like that. Vessel injury, I think, is talked about less, but you know, things like ehlers-Danlos, vascular component of it, is more likely to lead to like vessel wall injury and things like that. They tend to be prothrombotic. You can get them having very aneurysms and things like that as well, and they can also they're more likely to just get clots. So don't forget vessel injury. Generally, most of these things we're looking at are stasis or hypercoagulability. So I have wrote in my notes about thrombin time. I haven't actually seen this tested for. I think I've only seen people test for PT or APTT. PT is the one that is, you can work out the INR from PT. I don't actually know how to work it out. I usually just call the lab and ask them to put the number up for the INR, but you can work out an INR from a PT somehow. So if your PT is very high, you know, you're going to be checking if they're on warfarin and things like that, and you can give them vitamin K. Usually when we have patients who have a PT of above 15, we tend to give them IV vitamin K if they're about to have a procedure. So these are the bleeding ones. So people usually remember haemophilias are the bleedy ones. So von Willebrand's disease. So quick little bit of path, but I think this is useful. Von Willebrand's factor, if you remember, is kind of, I'm not going to go into too much detail with it, but it's kind of like an anchor on the vessel wall that lets, and then it kind of collects platelets onto it, so that it'll all kind of anchor there. It's kind of how I view von Willebrand's factor. It also has another, I don't know exactly how it does this, but it also kind of stabilizes factor 8 somehow, I think. So that's why desmopressin works, because it increases your amount of von Willebrand's factor. So you can give desmopressin as treatment for hemophilia A patients, because by giving them more von Willebrand's factor, you're also sort of improving how well the factor 8 works. But hemophilia B is related to clotting factor 9, so desmopressin doesn't do anything to that. Von Willebrand's disease, there are different types, but von Willebrand's disease tends to be either, it tends to be a quality problem with how it works, so it doesn't work well, or it tends to be a quantity problem, so you're just not producing enough of it. So if you don't have enough of that von Willebrand's factor, which is a thing that kind of helps aid the clotting process by sort of helping with this interface between the vessel wall and clots, if that's not working well, or you don't have enough of it, then you're going to end up having more bleeds, because you're not helping the clots form, essentially, is how I like to think of that. You can see I kind of like to think of things in a more simpler way. I don't like to get too bogged down in jargon. These are the more prothrombotic states. So factor 5 Leiden, the way that works. So it's a form of the clotting factor 5, which just doesn't turn off, essentially. So, you know, clotting factor is, well, making a clot. So if you've got a clotting factor that just won't turn off, you're going to get more clots. So that's why it's more prothrombotic. You get people can be either heterozygous or homozygous for it. So if people are heterozygous for factor 5 Leiden, then they can have approximately 50% of their clotting factor 5 is normal and 50% of it is Leiden. So it's still at an increased risk, but not as much as like the homozygous people who have 100% factor 5 Leiden. You know, this is very common. It's one of those things where people might not even realize they have it. They might just be slightly prothrombotic, but if they went for testing, you'd find out. And then you've got the SLE, lupus anticoagulant, antiphospholipid syndrome. That's all prothrombotic as well. You've got, you know, for SLE, you'll be checking for lupus anticoagulant. You're also checking for antiphospholipid syndrome, which is, the antiphospholipid syndrome is the one which is commonly in exam questions. I'll mention about a woman who's had like 3 miscarriages, and then you're checking to see if she's got antiphospholipid syndrome. I hope that answers the previous question. So that's why with the previous question, it was about which of these was, they were prone to clots. It would be the lupus anticoagulant one, not the von Willebrand's disease. Von Willebrand's disease makes you more likely to have a bleed than a clot. I will just check the questions to see. I think factor 5 Leiden is more common than antiphospholipid syndrome. I think double check that, but I'm pretty sure it is the most common one, because I think that also comes up as an exam question. Why do preeclampsia patients? I'll go through that later if you can remind me, because I will have to give that a bit of a think. Ooh, okay, right. Now this is an important topic, which I really don't think is explained well, but it is important clinically. And I'll explain why again as well. So the pentad on your right is for TTP, thrombotic thrombocytopenic purpura. The way that this works is that, so as I mentioned with the von Willebrand's factor, it's kind of this interface to help make a clot actually stick to the vessel wall. You can get ultra large von Willebrand's factor, which is like a large chain of these, and these are, it's cut up by Adams 13. It's a protease that cleaves ultra large von Willebrand's factor to just make von Willebrand's factor. Ultra large von Willebrand's factor is it's an area where you've got concentrated von Willebrand's factor. So that's more pro-thrombotic than your standard von Willebrand's factor. So if you've got, there are different types of TTP, but the most common type of TTP is you don't have enough Adams 13. Because you don't have enough Adams 13, you're getting these large stretches of von Willebrand's factor, you're getting platelet activation. So because your platelets are being activated in these spots, when you're sampling them peripherally, it looks like they've got low platelets because they're all in these the places where you've got this ultra large von Willebrand's factor. You're also getting a microangiopathic hemolytic anemia, a MAHA, because these are causing strands and they're causing, you know, the clots as well, and it's shearing the red blood cells. And then because you're getting all these clots are also firing into different places. They're going into the kidneys and you're getting renal failure. You're also getting, the neurological findings tend to be confusion. So it's quite, you know, more difficult to see. But when I was trying to look up why this happens, as far as I can tell, it looks like the clots are also going to the brain as well. And that's why you're getting confusion. And then you get this fever as well. HUS, which is hemolytic uremic syndrome, which is the one, you know, that you find out in peds where it's caused by the E. coli infection, and it tends to be children who get thrombocytopenia, renal failure, and MAHA. So they don't get the fever or the neurological findings. So as I said, classically TTP, get that pentad. That's what I'm hoping you would get in your exam questions. I think it's obviously difficult to tell because a lot, you know, like an E. coli, they might have a bit of a sepsis, so they might have a fever as well. But classically, so I think the best way to differentiate between these two is by the neurological findings. And hopefully with HUS, I'll mention something about like an E. coli. If they maybe had, I think there's like a question where they talk about, there was like an outbreak in Germany with lettuce, if I remember correctly, to do with E. coli and all these sorts of things. But that's the difference between HUS and TTP. Those are both MAHAs, okay? Both hemolytic anemias as well. DIC, it's a pro-bleeding state again, because what happens is that you get widespread activation of the clotting factors by the extrinsic pathway, but that's not important. You get widespread activation of the clotting factors, so you then have low level of clotting factors available for actually making clots when you need them. They might have low platelets as well. They don't always have low platelets, but because they've got low levels of clotting factors and they're not able to make clots, it's a bleeding problem, essentially. It's kind of how I like to view it. What will happen is that clinically, DIC and TTP and HUS patients as well are usually very unwell. DIC patients are often septic patients as well, and they're very unwell. You're getting your seniors in quickly because these patients do die. And what you want to do, because as I said, TTP is you're getting these platelets activated and they're causing clots, which are causing anemia, it's causing renal failure and all these things. So you don't want to give TTP patients more platelets because you're just adding more fuel to the fire. But, you know, as an F1, my job is often that I see an electrolyte or, you know, the hemoglobin platelets are low, I replace it. But this is a situation where if you see a low platelet count, you want to check the Adams 13 beforehand, because if the Adams 13 is low, then you're worried about TTP, and then you don't want to give them more platelets because you're adding fuel to the fire. If the Adams 13 is fine, it's more likely to be probably more of a DIC type picture. And so in that case, you can give them platelets. So you can give platelets to DIC, don't give platelets to TTP. ITP is this idiopathic, or it's now called immune thrombocytopenic purpura. It was just kind of like a footnote in my heme path type thing. I haven't really seen much of it in exam questions as far as I'm aware. Essentially what it is that you get an acute ITP in children after an infection, and in adults you get chronic ITP because it tends to be due to an autoimmune disease. But these patients are not sick, so I think you're less likely to come across this, and I haven't really seen it much in exam questions myself. In liver disease, you'll get low synthesis of clotting factors. Platelets aren't affected because platelets are made in the bone marrow, they're not made in the liver, by the liver. But you are getting, because the liver produces clotting factors, you do get low synthesis of clotting factors in liver disease. So I think, yeah, here's another question. This is, again, as you can see, it's a bit skeletal because it is someone trying to remember it from a past paper question. So let me just get these polls. Launch polling, it's done. And I'll have a look through your questions again. So the most recent question I see is, what is the mechanism of heparin-induced thrombocytopenia? To be honest, I think I have looked this up, and from what I remember, the pathology is not actually properly understood. It's and I think it's pretty uncommon. I haven't come across it much myself, either on heme or from what I remember the questions. Usually, I think they'll make it quite obvious in the question if they've been on heparin before. To be honest, I think it's something I should look into more. I should probably have done more research into that one. Because I'm not sure what the pathology is for that one. I haven't come, you know, when I was clinically, what I was always asked by the doctors is just to make sure that I'm very happy with the difference between DIC and TTP, which I can go into again in more detail later. And let me have a look. And then someone also put a question earlier, sorry, about isn't broccoli the one with warfarin? Warfarin, because it affects the vitamin K. Vitamin K is in like your leafy vegetables, so it is in broccoli and things like that as well. So broccoli does affect it, but it's just because of the CYP inhibitor things. I think grapefruit particularly affects that. So people who have grapefruit will affect their warfarin dose, which is why I mention it. Okay, so and we'll have a look at the answer. Yes, you guys, okay, cool. I feel like I labored that last slide quite a lot, but I think it's important. I think the pathology matches up pretty nicely, and I think it's important clinically, and I just feel like because it's such a nice point to teach, I don't know why it's not taught better. So I'm glad that you guys are happy with that. So as I said, it was quite a skeletal question, but it's because long APTT, long PT, they've obviously got low clotting factors because it's taking a long time for them to clot, so the clotting factors in those pathways are low. High D-dimers, D-dimer is measuring the clot breakdown factors. So this person's also making clots, they've got high D-dimers, and they're bleeding. GIC, as I said, is like a bleeding problem because they haven't got, they've got low clotting factors, so they can't make clots, they end up bleeding a lot. So that is good. Why isn't it liver disease? So liver disease would, so you can get the bleeding. It's the high D-dimers would point you, I think, in this situation to the DIC because it shows that they are having some clots. Liver disease, it's just you're not producing any of those clotting factors. So yes, you might have long APTT, long PT, and you might be more likely to have a bleed. You can still get bleed, you know, you are still likely to have bleeds with liver disease, but you wouldn't have evidence of clots, which is what the D-dimers are pointing to. Okay, so cancers. As I said, this is quite a buzzwordy area. So what I've done is I've got slides on the different, so on like the leukemias and lymphomas and things like that. So I might, if I've got time, I will go through those very quickly later. But essentially, I'll just go through it very briefly so you kind of understand the difference between them roughly. So if I go through the investigations, so don't pay too much attention to that diagram on the right, don't bother learning it at all. It's what happens is generally, from what I've seen, for people who've had like a leukemia or a lymphoma, it tends to be, if I go through leukemias, because I think that explains this a little bit more easily. Addenbrooke's is a tertiary centre, so I tend to see patients who have been brought from another hospital as a transfer. The reason why they're concerned about a leukemia in a patient is because it tends to be that a patient will often have an infection like a chest infection or something, they check their full blood count, because that's one of the standard blood tests, and they see their white cell count is like 30. In ALL, it can go up to like 200. And usually people are on about a 10 or so if it's raised for an infection. So when they're that high, they're worried that this is a leukemia and this is uncontrolled division of these white cells. They'll do a blood film to help have a better idea of what the cells are looking like. The cytochemistry, this immunohistochemistry, is when they do staining on those blood films to try to work out what sort of cells they are, because I think you guys will have to still do stuff in the labs when you're having a look at blood films yourself, and you're like, I know this is a red cell, I know this is a white cell, but trying to work out what all the different white cells actually are can be quite difficult between like your monocytes and your basophils and things like that. So that I think can help with that. You have everyone before they go for chemo will be going for a bone marrow aspirate and trophine. So aspirate is like they literally take some bone marrow blood. Trophine is when they get a sample of bone marrow tissue. It's essentially, for cancers, you've got to biopsy everyone to work out exactly what sort of treatment you want to give them. It's a bone marrow biopsy. A leukemia is a problem usually in the bone marrow, and so that's why you want to biopsy it. That's basically what that is. For lymphomas, you want a lymph node biopsy, because that's where the problem is, it's in the lymph node. I'll go through sort of presentation of lymphomas a bit more later as well. You also, especially if you've got like your bone marrow trophine, you'll be doing flow cytometry, which I think is like through the, like chemistry A level, they talk about mass spectroscopy and all that weird thing. I think that's partially what they do for working out flow cytometry, immunophenotyping, which is when they look for these particular antigens, which is why I've got this image on the right, because you can see that the antigens are present at different times in the cell's life cycle. So they can work out what helps tell them exactly which cells, and helps tell them sort of which part of their cycle as well. So if it's, you're telling if it's a lymphoid stem cell, if they've got like TDT, or if it's a properly differentiated B cell. Cytogenetics is looking at the chromosomes. So for example, with your CML, that's your translocation between 9 and 22 to get your Philadelphia chromosome. So that's why they do cytogenetics, to try to help with those sorts of things. Molecular genetics is looking for specific genes. I don't think you really come across this in exam questions, because this is very post-grad, but like what I found is when we're doing specific gene testing for our patients to find out, to work out exactly what sort of chemo drugs to give them, because there are certain gene mutations which mean they're more likely to respond to this or that. So you don't really need to worry about that in your questions, but it's just kind of explain what the different investigations are. So generally, I always have this, I constantly Google this picture because I get it and it's just such a pain. Leukemias are a problem with thrombocytes, erythrocytes, and with your white cells as well, generally. So you're going to get more bleeding, bruises, anemias, and you're also going to get, they're more prone to infections. As I said, usually I see people who are presented because they've got a really bad chest infection, and then when you clock them, you take a history from them, you find out, oh, they've been getting loads more chest infections recently. You find out that they've been getting bruises that they can't explain why they get them, and all these sorts of things. But yeah, the lymphomas, they tend to present because it is as I said, it's a problem with lymph node, or multiple lymph nodes and multiple lymph node regions, but it's a problem in the lymph node. So people tend to present usually with the standard constitutional symptoms. So they get their fevers, their night sweats, their weight loss, all those sorts of things. They might also get a bit of a mass effect. I think they talk about if they've got sort of weird leg swelling because it's affecting their lymphatics, they've had like unilateral leg swelling and things like that, but that's pretty unusual. I haven't really come across that. Usually what I've seen is that it tends to be someone has to have a CT scan for something else, and then they find these enlarged lymph nodes, and then they say that's when they get sort of hematologists involved, and they say, that this might be a lymphoma. And then the hematologists say, you need to biopsy it before we can properly take them on as a patient, because we can't treat them until we know what that lymph node shows histologically. So that's when you get your B cells, your T cells. I won't go into too much detail with this because there are loads of different types. You get your Hodgkin's lymphoma, you've got your non-Hodgkin's, and then your non-Hodgkin's, you've got your B cells and your T cells. I'd say that there are some of those lymphomas which are associated with other conditions. So you've got enteropathy-associated T-cell lymphoma. Enteropathy, it's associated with celiac disease, so they usually mention that in the question. But B-cell lymphomas, is you can get some which are associated with like Sjogren's or like Helicobacter pylori infections, and with those mucosa-associated lymphoid tissue B-cell lymphomas. The most common one that I've seen, and I think that's the most common one, is a large B-cell lymphoma. But it's just a whole topic. It's the other thing that the other lymphoma I'd mention is Burkitt's lymphoma. So these are all, I have written down some of these in slides, but this is all kind of stuff that I've kind of written for my notes. You might want to do some more from it, or just do sort of exam questions to see what sort of topics come up. But it's a very complicated postgrad area, I think. But Burkitt's lymphoma is the one which is usually, they usually talk about it in young children who get like a massive lump on their jaw. It's really fast growing. So that's to kind of get into our next question. Okay, tumor lysis syndrome. Launch poll. A lot of questions are coming up, and I'm aware of time as well. Hodgkin's lymphoma generally actually has quite a good prognosis. It depends, to be honest, the non-Hodgkin's lymphomas are, I know it's kind of weird that they've grouped it as Hodgkin's and non-Hodgkin's. Non-Hodgkin's is a very broad group in itself. So generally Hodgkin's has quite a good prognosis. It tends to be young people sort of in their 20s, and they often respond quite well. Generally, I'd actually say a lot of the lymphomas are curative. So this was actually something I remember one of the consultants was talking about for, with all the stuff with COVID, that technically lymphomas, cancer is bad, but they are often curative. So the patient, it shouldn't have an impact on their prognosis, like their lifespan or anything. But obviously it's just quite a lot there. Let me have a look. Right, end poll, and I will explain these ions so that hopefully you don't forget this in an exam. I'm exactly the type of person to remember this, and then when it gets to an exam, everything leaves my head and I don't remember how it works, so I have to work things out from basic principles again. So the reason why the answer is D is because, so as I said, with things like Burkitt's lymphoma, it's this really big lump. So Burkitt's is the fastest growing, and you just got lots of these cells. When you start someone on chemo, and often you give steroids as part of a chemo regimen at the beginning to help dampen down their immune system, you break those cells, you lyse those tumor cells. So when you have tumor lysis, your intracellular ions are all released extracellularly, when you take a blood sample. So the highest, the most common intracellular ion is potassium. So potassium is going to be high, and I think B and C were the most common options there, so that's good. Phosphate is also intracellular, so that's why the phosphate is also high. The calcium is low because phosphate binds with calcium. So calcium is a common extracellular ion. So when the phosphate binds with the calcium to make calcium phosphate, you end up getting low levels of just calcium ions. Uric acid, as I said, these cells are very quickly growing, so there's a lot of DNA synthesis. When you have those products are released into the blood system, and there's a lot of metabolism from the DNA synthesis pathway, you make a lot of uric acid, and uric acid, once it gets to the kidneys, causes kidney failure. And so that's why actually, from a clinical point of view, it's the uric acid which is the major problem. You want to give them, when you start someone on, when we have a patient with lymphoma and we're starting them on their chemo, we want to do tumor lysis bloods. So that's checking your USNEs, your bone profile, and making sure you add on uric acid as well. And you are checking them twice a day, and you give them allopurinol as a prophylactic medication. Allopurinol, raspberries, hopefully those are kind of ringing the bell from gout anyway, because that's also uric acid. If they're at really high risk of tumor lysis syndrome, if they've got a particularly like a big a lump or something like that, then you can give them rasburicase prophylactically as well. But generally, you can just give allopurinol and you give rasburicase as a treatment option. Generally, you'll see that their creatinine and their creatinine is going off, so it looks like they're going into kidney failure when you start them on chemo. So hopefully that will make sense for the tumor lysis. It is now 5 o'clock. I don't know if I can continue. I'll go on for a bit longer until I stop. So for allos and autos, if I go through it very briefly, I don't know how comfortable you guys are with just what it is. Allo is when you've got a donor. So what will happen is that you tend to have, you know, when someone gets diagnosed with like a AML or something, they will ask the patient if they're willing to look on the register for a donor. They do all the matching HLA, matching, et cetera, et cetera. Then with the patient, they give them chemo and sometimes radiotherapy. It's total body radiotherapy, so it's very intense. And then afterwards, after they've given them this sort of regime beforehand to wipe out their bone marrow, they then give them the donor's stem cells to recolonize the bone marrow. It looks like a platelet transfusion. That is what, you know, they don't have to go to theatre or anything. They can just be in their own room and they get this transfusion IV. It also, as a fun fact, smells of tinned sweet corn. So I've had patients complain about that. Autos, what you're wanting to do is it's coming from the patient. So you want to give the patient GCSF to make their bone marrow produce some more cells. Then you're harvesting them. Then you're doing the same thing of wiping out their bone marrow. And then you're giving them the stem cells packed and reintroduce it. Generally, people who have allografts look rotten when I see them on the ward. Autos, sometimes they still look a bit rotten, especially if they have complications, but they generally actually look quite well. Auto is definitely a lot less difficult on a person than allos. And then looking at the complications, again, this is something where I talk to other specialties and they hear it's a heme patient, they're like, oh my God, yes, I'll come review the patient for you because they know that they're complicated. For all our patients, we give them ciprofloxacin, acyclovir, and fluconazole as prophylactic treatment. Ciprofloxacin to cover for any bacterial complications. They're more likely to get positive gram-negative bacterial complications, pneumococci, H. influenzae. Viral, they get, so ACE is adenovirus, CMV, and EBV. HSV, herpes, I'm often checking patients in their mouths. I'm looking in their mouths for candida. I'm also looking for any ulcers because they might get, more, the reactivation of herpes. And so then you just want to swab it to check for herpes. BZV, varicella, HHV6 is something which is, they mention all the time. It's one of these things where there isn't like a very clear presentation for HHV6. So HSV, I can say, oh yeah, that's an ulcer. CMV, for ACE, we do blood tests twice a week to check to see if there's a reactivation of them. CMV is one thing that can come up as like a pneumonitis. You can get it as a retinitis, so it affects loads of different conditions, loads of systems, sorry. HHV6 is something which often kind of just appears a bit of like a headache, a bit of just feeling rotten, which a lot of these patients feel anyway, just from having these stem cell transplants. So I wouldn't really worry about that unless, I don't bother about that. The hematology consultants just asked me to look for it sometimes, and it was in my notes. For fungal, fluconazole, you're looking for candida. As I said, it can be in the mouth. You can get it further on in the esophagus. So, and this was an exam question that I saw as well, but like I've had this as a patient on the ward round was complaining of chest pain, mainly while swallowing, but me being an F1 went, chest pain, troponin and ECG. And my heme consultant said, no, I think it's actually just esophageal candidiasis. They had nothing in their mouth, but it might not affect their mouth, it might just affect later on in the esophagus. But the main thing was that it came on mainly while swallowing. And then you just, you can give them the treatment, fluconazole and things like that. Aspergillus, that's mainly causes a sort of chest infection. What we tend to do with our patients is we give them, if they have 2 fevers of above 38 degrees of over an hour apart, we just start them on antibiotics, on tazocin, or whatever your local antibiotic guidelines are for neutropenic sepsis. We start them on antibiotics, and if after 48 hours, they're still spiking temperatures and they haven't responded to antibiotics, then we go for a CT chest to look for if there's any indication of a fungal chest infection. The reports never say, yes, this is fungal, or no, this definitely isn't fungal. Usually they'll say, this is unlikely to be fungal, or they'll say, can't exclude fungal. If they can't exclude fungal and they're still not responding to antibiotics, then we go for a bronchoalveolar lavage, where we actually sample to check if there is a fungal infection there. PCP is, so it's another fungal infection that patients can get when they're immunosuppressed. Also, as you might have noticed, that a lot of these immunosuppressed type things will overlap with like what HIV patients get because they're just very immunosuppressed. But with PCP, you want to give them cotrimoxazole as a treatment instead. And with PCP, it is, actually, I'll explain this because I've got a question on this as well. But it's, I'll just answer the question. GVHD, I kind of already explained a little bit earlier about what GVHD is like. But what tends to happen is that because it's the graft's immune system affecting the host's immune system, when patients go home, they're slowly weaned off the immunosuppressant medication. There'll be a point when they suddenly get a rash. It looks very much like sunburn, or if it's really bad, their skin is peeling, or they're complaining of sort of almost uncontrollable diarrhea. They're just having, like 9 times a day, because GVHD tends to affect skin and gut the most. So then, because it's a problem with the graft's immune system attacking the host, you want to dampen down the immune system. So that's why you give them steroids, and usually they're already on like tacrolimus. As I said, you're weaning it down, so you just go back up again. So that's how you treat the graft versus host disease. Graft versus host disease does also affect lung and liver, but liver, like, you won't really notice clinically. You'll just notice that the LFTs are starting to go off. And lung, I haven't seen any of it at all on heme, and I haven't seen it in really exam questions. Let me go back. Launch poll. A lot more questions. I haven't seen any gout in TLS patients, to be honest. ACE, as I said, is adenovirus, CMV, and EBV. Cotrimoxazole, everyone goes home on prophylactic cotrimoxazole. How common? Oh, GVHD does not happen in autos, because the whole problem is that it's the graft, it's like a donor's immune system attacking them. So actually, I should mention that as well. GVHD does not happen in autos. It only happens in allos. If cancer patients on tacrolimus does not put them at greater risk of squamous cell cancer, possibly. I don't know my skin cancers very well. It possibly does, but generally, like with all these patients, especially as I said, with like Hodgkin's disease patients, they are often in their 20s getting chemo, maybe, I mean, usually it's chemo, and then they can get a bit of radiotherapy as well. And chemo and radiotherapy increases your risk of getting cancers. So a lot of patients with Hodgkin's disease, just by having chemo and radiotherapy, are at increased risk of getting other cancers later on, which could be like breast cancer if they've had radiotherapy over that area, that sort of thing. So these drugs, heme drugs, are bad. I'm not allowed to prescribe a lot of them. I have to go straight to my reg, and she decides what, she prescribes them. I literally cannot prescribe them. If you're all okay with time, I know I'm overrunning. I will. Okay, gonna end up there. So this one is PCP. That is fine. I'll go through this in more detail. But I was worried I gave it away when I was talking about PCP, and I was like, oh no, I've got a question on that. But that's fine. So essentially, PCP is very classically that the main thing that would point me towards a PCP is the fact that they desaturate so much on exertion. Interestingly, PCP and COVID-19, I think, actually often present quite similarly. COVID-19, they often have this quite significant desaturation, dry cough, shortness of breath. And if you look at their chest x-rays for COVID-19 and PCP, they actually look quite similar. PCP is, however, a fungus that is just found everywhere. Like we probably all have PCP as well. So it's actually, and I've talked to an infectious diseases doctor about this, when we test patients, as I said, we tend to give them antibiotics. If they don't respond to antibiotics, then we do a CT chest. If that doesn't exclude fungal, then we go to a bowel. When you do a bowel, you will almost certainly pick up PCP. It's just deciding if PCP is actually the thing that's driving this chest infection in this patient. If you think it is, then I will go on to what medication does he require? This isn't actually like a question from the poll, because I already had it on my previous slide. It is cotrimoxazole. Cotrimoxazole is the best one. You give it prophylactically. They tend to have it on a Monday, Wednesday, Friday, if it's prophylaxis. If it's treatment dose, then it's a higher dose and you get it every day. Hemolytic anemias. This is, I'm aware of timing as well. So, I mean, everything after this will be very quick. It's mainly actually just giving you my notes. I don't really have much more else I want to explain in a lot of detail. So for the hemolysis, so these are the hemolysis bloods. In anemia, your hemoglobin goes down. Because it's actually breaking up the erythrocytes, you've got a high unconjugated bilirubin. So when you do your LFTs, your bilirubin will be high. You'll often want to add on a blood test of total conjugated, unconjugated bilirubin to check that it's unconjugated. Lactate dehydrogenase, you want to order that as a blood test. Haptoglobin, you want to order that as a blood test. So your lactate dehydrogenase will usually be high because of the hemolysis. For the haptoglobins, that's a sort of binding thing, so that will often be high as well. Your reticulocyte count will be high because you've lost a lot of your red blood cells, so your bone marrow is trying to compensate by creating a lot of reticulocytes to make your erythrocytes. On your blood film, you'll often show, it depends. Blood film, yeah, so for a blood film, it will usually show schistocytes, which shows that you've got these fragments of red blood cells to show that they've been broken up. And then DAT, or your Coombs test, as well as sometimes shown in some things, is an antigen test, and that's for helping to work out what type of condition you have, which is contributing to this hemolysis. So this is copied from my pathology notes. As I said, I spent more time on heme path and other path topics. I'm going to go through it very broadly. This is also how one of the heme consultants taught me for this. For your inherited hemolytic anemias, just look at how an erythrocyte is built up. You've got your membrane, you've got enzymes inside it, and you've got your hemoglobin. If it's a membrane problem, it's you're looking at spherocytosis, elliptocytosis, and then path goes into all the details on like spectrum, whatever. You don't need to worry about that, you'll get that from blood film. Enzyme deficiency, you're looking at G6PD deficiency, pyruvate kinase deficiency. G6PD deficiency is the one that's often brought on by drugs. So often things like antimalarials and things like that, they'll mention that in the question, and that will point you towards a G6PD deficiency. Or fava beans, that's the other classic one that they like in their questions. Sickle cell is a huge topic in itself. I'm not going through that. The only things that, when someone says sickle cell to me, the two main things that I think of is that you get your chest crises is the thing that actually brings people into hospital the most who've got sickle cell. And then you want to be giving them things like oxygen and morphine and contacting hematology. Thalassemia, the main thing to look out for in exam questions for thalassemias is that the MCV is disproportionately low compared to the hemoglobin. So the other main thing when you're looking at anemia, if it's not hemolysis, is if you're looking at just the hemoglobin and the MCV, in your iron deficiency anemias, you'll have a low hemoglobin, and when you see enough questions, you'll kind of see roughly how low the MCV is compared to the hemoglobin. In thalassemias, you'll notice the MCV is disproportionately low. If it is, and you're looking towards a thalassemia rather than an iron deficiency anemia. Obviously, you can have a look at the ethnicity. I think it's more Mediterranean people, but I have also seen exam questions where it started off with a Greek lady and then it had nothing to do with her ethnicity. They shouldn't be doing that in exam questions from what I've been told, but I have seen that. So don't do it just based on ethnicity. The best way is, I think, to look at the hemoglobin and MCV. And then you've got alpha beta, and it goes into all those subgroups there. For your acquired, this immune-mediated branch, I'm not going to go into because it's weird stuff that I haven't really come across in exam questions or clinically. You're non-immune mediated, so that's your DAT negative because that's an antigen test. You're thinking of your malaria because you know that's part of the life cycle. It goes into your erythrocytes and makes mixed fluid, so it's hemolyzing the red blood cell. You've got your MAHAs, which I've talked about already. You've got your mechanical metal valves for the heart, you know, for the valve replacements in the heart. The metal valves in particular are, they, you know, when the red cells go through, they just chop them up, so you get hemolysis again. And in your paroxysmal nocturnal hemoglobinuria, I'm not really going to go into detail. It tends to be people have dark urine first thing in the morning, with your hemolysis, with the bilirubin and stuff like that, you know, that goes into the urine and you get a dark urine. And they tend to get hemolysis overnight for some reason, and that's why they have dark urine in the morning. That's what it'll say in the question if you're pointing towards that. So, nearly went on to the question there. On to the answer there. So launching the poll for this. So I know there are lots of questions that I haven't actually answered. Some of these I'm not sure. So what I'll probably try to do is I'll try to look them up, and maybe when these slides are sent around, I'll try to answer those questions as later slides. Difference between LDH and lactate. Lactate dehydrogenase is an enzyme, whereas lactate is the actual like product, lactate. So LDH tends to be, because it's an enzyme, it's going to be raised in things like heart attacks and things like that. You can get a raised LDH, and then in hemolysis, I think, I'm not sure why. I don't know if LDH is in erythrocytes, which is why it's released from there. I'm not quite sure. But lactate is a very non-specific way that we use clinically just to check if a patient is well or unwell. Let me have a look at the polls. Okay, cool. So the answer is TTP because, and actually I'm glad the majority of you have made this mistake, because this is what I wanted to point out. You might get a blood film. I think it's unlikely. I think it's more of a path thing. But as I said, it is, you know, something that you would do as part of your hemolysis screen. In G6PD deficiency, you get your bite cells, which is what I think you guys thought these cells were. For bite cells, they generally look like a cell that has just got one bite taken out of them, like they've just got one like tooth mark in it. These cells they're like half a cell, or you know, maybe slightly more, slightly less, but they look like they've had multiple bites taken out of them. So that's why these are not bite cells, these are schistocytes. They are fragments of red blood cells. G6PD, you know, you can have a quick Google of it later. I haven't got any images myself, I'm afraid, sorry. But it looks like just one bite's been taken out of it. So that's why this is TTP, because you've got your microangiopathic hemolytic anemia, and because you've got your hemolysis, you know, because of, as I said, because of those things of from the ultra large von Willebrand's factor and things like that, you're getting shearing of the red blood cells when they pass through, and that's when you get these schistocytes. It's not iron deficiency anemia. You'd get your hypochromic, microcytic, you know, that they just look a bit less red, they look smaller, and you might get your weird pencil cells, which they like to mention. Megaloblastic anemia, you'd be looking for a hypersegmented neutrophil. That white cell count, that white cell looks fine. CLL, you get your smear cells, which again, it would be a white cell, and it would just have one edge which kind of blends in with the background. That's what a smear cell looks like. Okay, right, done. I'm sorry guys, I overran. I can still go through things. I don't know if you guys want to leave. These are essentially my extra notes for you guys. This is the whole diagram, you know, showing the management, showing the signs and symptoms. This is my list of buzzwords, as I said. what I'll do is that there's usually one or two things which I kind of want to elaborate on this slide. So I'm going to continue, if that's okay. But you know, there's a note to check the feedback. If you need to go, please leave feedback. I'm sorry I'm overrunning. What I'd say with this slide is that for APML, that's acute promyelocytic leukemia. The main issue with that is bleeds. You get like spontaneous intracranial hemorrhages. APML is one of the few times I've seen hematologists look really twitchy. Like the heme consultant looked genuinely worried about a patient, and that's because he was worried about them having a sudden major bleed that you're not really going to fully recover from. Otherwise, these are things like ALL you get like it's in your children and things like that. CLL is the fact that for Richter's transformation, that's just the fact that a lot of people with CLL it can transform into Hodgkin's, but that's a very like fine print thing. I wouldn't worry about that. These are my notes, as I said very briefly, about the different types of non-Hodgkin's lymphomas. For Hodgkin's, as I said, it's usually people in their 20s. You read Sternberg cells or Owleye cells. Learn this staging system, the Ann Arbor staging system. Really easy to learn. I think it's the easiest staging system to learn for exams. And you can get questions where they just give you a stem and they go through it and you just need to stage it. So learn it. I'll go through this last question. I have not gone through myelomas, obviously. Wonderful. This is the last question. And then I'll let you guys go soon, sorry. Also, you have loads of questions. I know you were asking about when you prefer to give FFP to a patient, so I didn't actually go through that. It tends to be, I would say, the most I've seen it's actually been in like, again, with the trauma anticoagulant, with the trauma patients. Generally, you don't need to give it to patients because it's fresh frozen plasma, it's a clotting factor thing. I haven't actually seen any DIC, so I'm not sure if you'd want to give it in DIC when their clotting factors are low, because I'm not sure if you're adding fuel to the fire on the DIC by giving clotting factors. The only times I've seen it has been for a trauma patient. You know, if they're bleeding a lot, obviously you want to give them red blood cells, but red blood cells are just packed red blood cells, so you're not replacing all their clotting factors and things like that. So they usually have, I mean, it seems to be different centers have different ways of doing it, but they'll give a certain amount of red blood cells, a certain amount of fluids, a certain amount of FFP to all their trauma patients when they've lost a huge amount of blood. That's the most common time I've seen FFP used. I can check about it in DIC because I think that's the only other thing I can think of. So if I end all there. Yeah, myeloma. This is taken from an AMISAM lecture. So you could guess this is probably going to be myeloma because this is also a hematology lecture on my behalf. But the important thing here is that you've got a normal ALP. I can't really explain why, but you have backache because you get a lot of fractures and things like that. Hypercalcemia, that's usually how they present. Myeloma is actually talked about more often than not of these other things, just because if you get a patient with high calcium, that's you're going to be checking them for myeloma, even if they don't actually have, and if I go through the rest of it, these are kind of my buzzwords for myeloma. Even if they don't, you know, for CRAB, it's a high calcium, it's renal failure, it's anemia, and then bone fractures. They're not often, like I've seen patients who have had a high calcium, but their hemoglobin's fine and their creatinine's fine, but we still end up doing a myeloma screen, which is looking for immunoglobulins, looking for Bence-Jones proteins in the urine, all these sorts of things. Because it tends to be a high calcium problem, you're usually treating people straight away with fluids. If they're overloaded, you give fluids and furosemide. And because this myeloma is a cancer, you can actually give bisphosphonates in these patients, but don't give bisphosphonates unless it's confirmed cancer, because the reason why you don't want to give bisphosphonates when it's not a confirmed cancer is there's a risk of tipping them into hypocalcemia. I did see an exam question as well, which I haven't included here, where they asked exactly what the type of lesion is. It is damage, like it's a lytic lesion, because you're lysing in a way the bone. You're actually, like, it's osteoclast activation, so you're actually destroying the bone, so that's why it's lytic, rather than sclerotic, which make it sound like it's kind of gone a bit funny, kind of died sort of thing. I'm not going to go through this because these are just kind of like definitions for these different things. MGUS is the one that I have briefly come across, but it's a kind of thing where people don't really, unless they're actually having any symptoms of like a hypercalcemia or anemia or renal failure, you don't really want to do a huge amount for them. You tend to just monitor for them. It might be that you've just found out while doing blood tests for other things that their immunoglobulins are quite low. These are just what I kind of had in my notes for differentiating between these different conditions, which they often talk about. Right, I'm sorry guys that went over by like 25 minutes. We've lost a good portion of you. Here's the feedback. There are, sorry guys for taking so long. I also had a question about explaining the TTP. So I'm going to do that one last time if that's okay. So for the TTP, the way that's, so you've got the pentad. Remember, pentad is definitely for TTP. The way it works from a pathology point of view is that it is a problem with, usually, it depends exactly on the type of TTP, but it's usually a problem with not having enough Adams 13. Adams 13 works by cleaving ultra large von Willebrand's factor, which is a whole load of, like a whole chain of von Willebrand's factor, and you cleave it up. Because it's a lot of von Willebrand's factor in a concentrated space, it's very pro-thrombotic. It's really catching a lot of the clotting factors and platelets and things like that. So you're making clots and you're getting strands. And so that's causing the MAHA, because it's causing, when the red blood cells are going through the strands, they're being sheared. It's also just creating a lot of clots that fly off. The clots go into the lungs. I think they also go into the brain, and that's why you get renal failure and you get confusion and neurological symptoms. But it's really a problem with the clots, and it's usually, but not all cases of TTP, but usually because of a low Adams 13 level. So if you've got a patient clinically who's got a low platelet level, you want to be checking their Adams 13, because if it's low, then you know that it's a patient who's got TTP, and they've got these long chains of von Willebrand's factor, which is catching all their platelets and sending off clots, and it's also sharing their red blood cells. So if you give them a platelet transfusion and you give more platelets, then you're giving more platelets to be caught by that von Willebrand's factor and everything else, ultra large von Willebrand's factor. So you're causing fuel to that fire. I hope that explains it. Okay, thank you guys. As I said, I mean, to be honest, my voice is going and my brain is trying to catch up. So I will answer the rest of these questions. I'm sorry, I didn't answer all the questions. I'll answer the rest of these questions, as I said, and I'll put them at the bottom of my slides. And we'll get those out to you. So I'm sorry I haven't answered everyone's questions. Heme is a big topic. And sorry again for overrunning. I hope you all enjoyed the lecture. Thank you. Leave feedback. Bye, everyone.